Hey, this is Dr. Amanda with StraightSmile Solutions, StraightSmileSolutions.com, and today we're going to be talking about anterior open bites in both growing patients and in adult patients, what you should be doing. I'm posting this just because I keep seeing doctors moving forward with open bite cases. They look at these simulations that they might get from certain aligner companies, and they're like, oh, well, they said we can fix it, so we want to just do it. And it's frustrating because I know that this isn't going to work. You might be able to get that correction, but it's not going to stay. I know this because I've been doing this for 18 years and I've treated so many people's retreatment open bite cases. Open bite is a vicious cycle. So, unless you play detective on the front end and find out what's causing it and what's perpetuating it, you will never be able to keep it closed long term. It will just always be coming back. So, and I think that a lot of these aligner companies are doing both the doctors and the patients a disservice by just saying, yeah, sure, we can fix this without explaining to them the complexities of the open bite. So, anyways, whenever I see an anterior open bite, whether it's an adult or the kids, there's like a certain checklist I recommend. And doctors who's worked with me, they know this. So, first thing would be some type of sleep questionnaire, either a kids one, a sleep disordered breathing one in kids, or an OSA one in adults. Depending on what you see from that, you may need to escalate that and either send them to a sleep physician, or an ENT. So if you get red flags on that, and you need to explain the why behind the questionnaire. This isn't something they can just do in the office. They need to have someone do it for them, like a wife or a husband needs to score you, while you're sleeping. A parent needs to actually stay up a few hours and score their kid. So you can't just fill this out. It takes many days to fill this out. And we'd like them to take several nights of listening and coming in different times and observing what they're seeing. So the second one would be Melon Potty scoring. That's where, you're looking, say seeing what you see. You're seeing kissing, you know, tonsils or whatever. Are they inflamed? You're going to see this maybe more in kids, but you see in adults too. Again, if you're having airway issues, that is a sign of why you're having the open bite. So you can't just it's a vicious cycle. You can't just treat the open bite, because if you don't treat the airway issues, it's going to come back, right? Adenoids can be seen often in a Ceph x-ray. Maybe that's not going to be part of your analysis, but if you are taking a Ceph, you can look for that. Just looking at the general nasal airway, if you have a CBCT or a Ceph, you can see a lot of things about the oropharyngeal airway, the nasal airway, in the Ceph. Look for mouth breathing clinically. It's something that I can see across the room, if somebody's doing it, and I can definitely see it in my chair. I might be able to see it in like a virtual consult, but I'd rather them be in the chair. And definitely Melon Potty would have to do in the chair, right? Tongue thrusts, again, I can see it and I can hear it when I talk to a patient, but it's something you'll need to train yourself to do. So I'd recommend maybe look up some YouTube videos of people who have tongue thrusts and just start looking for it so that you can see it. Once you see it, you can't unsee it. So if they're having tongue thrusts, again, that's going to be a counterforce. So even though maybe you're extruding those incisors, that counterforce is stronger than your elastics or your aligners or your braces. So yes, you can put on a bonded retainer and you could put on an Essex over it, but guess what? It's still going to relapse. So I can predict that if you have any of this stuff going on. Of course, you need to ask about oral habits too. You'd be surprised, and I can't say this too many times, because until you start asking, nobody's going to volunteer that information. A 50-year-old who sucks his thumb when he's stressed out at night under the covers or in the closet is not going to tell you that. You're going to have to kind of have that conversation. And I would say many of these patients did have habits as a kid, but you'd be surprised how many still have the habits now as an adult. And if you don't find out it's there and treat it, you will never be able to fix this case. It's going to go very unpredictable. So you need to have that conversation, because they're not going to release that information unless you ask. They're probably not even connecting the dots. And lastly, check the patency of the nasal airway. That's obviously where they're going to close their mouth and you're going to ask them to breathe out and see if you can feel the airflow. You want to feel nice airflow. If they plug one of their nostrils, if they constantly have, rhinitis and stuff, this is not, you got to fix that first. So they need to go to their allergist, go to their doctor, fix that first before you start fixing the open bite. All these things are going to make an open bite worse. Okay. So obviously, a growing kid is going to have more success than an adult that's done growing with open bite correction. But yeah, so this might mean not jumping straight into aligners or braces. It might mean either working with oral myofunctional therapists, which may or may not be covered by insurance, regularly during the treatment. But you need to get that commitment from the patient, get that in writing, so that that goes together with the treatment at an additional fee. Or if they don't want to do that, you can put in a habit appliance, a fixed one. I would definitely recommend 6-9 months ahead before treatment. You can start the treatment, but that's the first part of the treatment is the habit appliance, the tongue taming appliance. There's a variety of different fixed appliance. There's removable appliances they can wear at night. Obviously I would want them to wear it for maybe 6 to 9 months before. There are some removable appliances that could be worn over braces or aligners, but again, I hesitate to jump into this unless I know the patient is going to be compliant. So I think I would start that for a few months first. Again, you might need to send to ENT. They might need to get surgery. You might need to send to OSA. They might need to, there's so many things that may need to happen. So it's a very interdisciplinary situation, and you have to be a detective before you take on this case. So don't jump to take any open bite case just because the simulation or the treatment planners say you can do it. So this is my warning. All right. Thanks so much.